Thank you very much. And now, as I mentioned, our third and final speaker is about to begin. Dr. Ben Sipos is a pathologist. He's a molecular pathologist. He's in Baden-Württemberg in the town of Stuttgart in Germany. He's at a very special molecular pathology laboratory there, but also has great academic relationships across Germany, particularly with Tübingen. And I'll ask Dr. Sipos to begin his talk now. Dr. Sipos.
Bob, thank you very much for the nice introduction. Good afternoon to the audience. As Bob said, I'm classical surgical pathologist and a molecular pathologist also, and we run here a molecular pathology laboratory in southwest of Germany, where we offer a rapid NGS analysis, primarily using the Oncomine DX panel, and that is why I'm able to present our experiences today. So these are the disclaimers. We pathologists offer a molecular characterization of malignant tumors on a daily basis. It should be done, of course, from FFP tissue and should be as fast as possible. And we must manage it even from very limited tissue samples. This characterization is as comprehensive as necessary, depending on the entity and the molecular biomarkers which are relevant for the first or second line treatment. For patients who have exhausted all treatment options, we try to extract the maximum amount of information using larger NGS panels. Just a moment. Please allow me to briefly introduce the methods we use to detect genetic alterations. The most simple and very known method is the PCR, which is able to detect limited number of predefined variants, which are mostly point mutations. And it's ideal for follow-up of known variants because it's highly sensitive and quite inexpensive. If you are looking for comprehensive characterization, you have go for a targeted sequencing, which may contain from a few to even 600 genes on the panel. And this is very important, of course, for a comprehensive characterization of molecular alterations for progressive tumor diseases or for detection of resistance mutations. NGS is able to detect all kind of relevant variants, point mutations, deletions, insertions, copy number variations, and even complex features like microsatellite instability, tumor mutation burden, or homologous recombination deficiency. There are basically two NGS methods which differ mainly in terms of target enrichment. The first is the hybrid capture-based method, which uses DNA probes, which are complementary to the DNA sampled DNA. And this hybridization takes a little bit longer, but it's able to catch not only the target sequence, but adjacent DNA areas from the sample DNA. The second method is amplicon-based NGS, which uses a multiplex PCR reaction, which can be then barcoded afterwards. Due to the barcoding, we are able to reduce PCR artifacts and filtering them. Both methods has advantages and disadvantages, of course. The hybrid capture is characterized by a great flexibility. You can add new targets in an unlimited way. That's why in whole exome or whole genome sequencing will be done with hybrid capture methods, and it's better for detection of target variants, for example, for unknown fusions. And this is an open system. The limitation of the hybrid capture method is the relatively high need for input DNA, 40 to 80 nanograms. And the turnaround time of the classical hybrid capture workflows is not less than 5 days. The amplicon-based NGS can manage with very little input material, um, from even 1 to 20 nanogram DNA and RNA, and that's why it's suitable for small biopsies, even for cytological specimens. And in our hands is better for low quality samples, and the turnaround time with some techniques can be short as 2 business days. The limitation of the method is the quite complex design. You cannot add simply new targets. If you like to analyze new targets, you have to make a complete new design of the multiplex PCR. Among the amplicon-based methods, the ODX-ET offers further advantages. Um, this panel using molecular barcodes, as you heard about it from Dave. The reduction of FFPE artifacts is a very nice feature of this panel, and that's why we can use it for poor FFPE sample quality, which can occur in every lab. And the input DNA is quite low. And this is a combined parallel DNA and RNA sequencing with a very short hands-on time for the technicians because of this mentioned integration of the 2 main steps of the sequencing, library preparation and sequencing. It's allow me to present 2 recent cases to demonstrate the advantages of Oncomine Dx. The first case is a 70-year-old female who smoked long time ago. She presented multiple lung tumors, even lymph node metastasis, and unfortunately brain metastasis. The histology from the transbronchial biopsy showed a pulmonary adenocarcinoma, and this carcinoma had a very high PD-L1 expression. So if you are an oncologist in this dramatic situation, you may start with a chemoimmunotherapy. But if you have the options of a reliable and rapid NGS, you request this test, and this will have a significant impact on the course of the disease. In this case, we were able to detect an EML4 ALK classical fusion in a sufficient number of reads. And this NGS result was completed on the 3rd business day. And I calculated the total processing time for this presentation. It was from sending the sample to reporting 6 business days. The patient has been treated and showed a complete response in the lung tumors and an almost complete response of the brain metastasis. The second case is a 73-year-old man who presented lung tumors by CT either. The biopsy showed a pulmonary adenocarcinoma, and I like to show you the biopsy. You can largely see normal bronchial mucosa at the right-hand side and the bottom, and there's only a tiny area in the left-hand side which contains tumor tissue. This area is 0.3 millimeter large about, and estimated contains 60 tumor cells. I estimated the tumor cell content after microdissection about 10%. And we did the NGS sequencing using the Oncomine DX panel and detected a V600E BRAF classical mutation in a very low allele frequency in 1%. And we are very cautious if the number of reads lower than 100. That's why we need some kind of validation. And this is the strength of the parallel sequencing. We were able to detect PIK3CA driver mutation in a similar allele frequency and TP53 mutations also in a similar allele frequency. So you can, during this parallel sequencing, validate your results, and you can be sure that the mutation comes from the tumor, not an artifact. Our main areas of investigations are the classical entities like lung cancer, colorectal carcinoma, bile duct cancer, and of course, breast, GIST, melanomas, as in most laboratories in the world. And we are, as Bob said, we are located in a federal state of Germany, in Baden-Württemberg. That is a home of four large renowned university hospitals with large sequencing laboratories. And we founded our laboratory in 2019 with 14 pathologists together, and have since been able to gain many new clinical partners in the region, and we are now accredited. We perform about 5,000 NGS tests in the last 4 years, using this Oncomine, mainly using this Oncomine DX tests with the Genexus integrated sequencer. And integration is a big advantage we heard about it, because and that's why we have a very short hands-on time, and so we were able to achieve turnaround times 3 days in 80% and below 5 days in 94%. And it's most importantly, we have a drop-off rate of below 1%. So if I summarize our experience, I feel that a quiet revolution has taken place in NGS. The reliability, drop-off rates, and turnaround times are equivalent to the routine methods in the pathology like immunohistochemistry, and this allows us an optimal decision-making because the final results can be generated between the weekly tumor boards, and it's optimal for your patient care. Thank you so much for your attention.